So then we move on to the next person, neurological signs of neuroblastoma, Kevin Rostasy, Jr. Please.
Thank you very much for the invitation to come to Moscow, fairly impressive city, and I would like to talk to you about the spectrum of neurological signs associated with neuroblastoma, or a pediatric neurologist is encountered with. Briefly, there are two forms: either direct involvement of the tumor with neuronal structures, or we observe autoimmune-mediated diseases such as opsoclonus myoclonus syndrome and other paraneoplastic syndromes affecting the nervous system and also affecting other entities of the body. Tumor involvement of neuronal structures is actually, according to my experience from a pediatric neurologist sign of view, rare, but it can occur depending on where the tumor is actually affecting the nervous system. I've seen a child presenting with focal seizures or with cranial nerve palsies. I've seen one child who had a disease similar to a transverse myelitis infecting the myelin, leading also to gallbladder problems, and very rarely peripheral nerve affection can occur. The more interesting from a neuroimmunological point of view is, of course, autoimmune-mediated phenomena associated with neuroblastoma. And there have been several reports, for example, on a child with Lambert-Eaton myasthenic syndromes who had also a neuroblastoma. There's a child on record with an encephalomyelitis presenting with a longitudinal extensive transverse myelitis of the myelin, but also of an Adam-like picture of the brain. And there are patients on record who present with a pure cerebellar ataxia in association with a neuroblastoma. And recently, a child with a hypothalamic syndrome with temperature instability, hyperphagia, somnolence, sleep problems was described. But these are actually exceedingly rare cases, and the group which is more commonly observed in children with opsoclonus myoclonus syndromes in association with neuroblastoma, and I have to say without neuroblastoma. It's very important to have that definition right for opsoclonus myoclonus, and the leading symptoms is certainly the opsoclonus. And I will show you a couple of videos, and the eye movements must be conjugate and irregular, chaotic in all directions. The second neurological phenomena is ataxia, and you should have a stance, a gait ataxia, in conjunction with an intention tremor. Then myoclonia are very important. These are brief contractions of muscles over a joint, and they are irregular and they are asymmetrically often. The problem is that not all three symptom groups come at the same time, but they develop sequentially. And our fourth point, parents nearly always describe that their children are very irritable and they have major sleep problems. In Germany, roughly 10 to 15 cases per year, usually children between 18 months and 3 years, and at least half of all children have a neuroblastoma. And the rate of neuroblastoma can be increased significantly. There are researchers saying that nearly up to 90% of all children with opsoclonus myoclonus do have a neuroblastoma at some stage. And if you do chest X-ray, ultrasound, MIBG scan, and include a second line investigation with an abdominal MRI, including 4mm slices, then you can increase your detection rate significantly. This is shown here by data from Barbara Hero too, that over the years you have a slight increase of children with neuroblastoma and opsoclonus myoclonus syndrome. Some facts: 1 to 2% of children with neuroblastoma develop opsoclonus myoclonus, and what is interesting is that they are nearly all of low grade and low stage in the majority of cases. They are very rarely associated with an MYC amplification, and the localization of the tumor is in general perivertebral and thoracal. And very interestingly, if a tumor is removed, even months to years, the child can develop an autoimmune, I say autoimmune-mediated disease process leading to opsoclonus myoclonus syndrome. So the assumption is that this is most likely an immune-mediated disease process. I would like to show you a couple of videos too of patients with definite opsoclonus myoclonus. Both of them had no neuroblastoma. This is a 2-year-old boy who developed an unsteady gait with frequent falls over 4 weeks. And he was very irritable, had problems with sleep, and that's interestingly, the eye movements only developed after the child had a marked ataxia. And 10 days later, the mother noted the peculiar eye movements and then went to see a doctor. So this is... Please have a close look at the eyes. And you have to observe it very carefully to see this rapid eye movement. It doesn't have to be permanent, it can be episodic. So you can, even if you examine the child, you can miss this eye movement pattern. He's actually quite happy at present, but he was very markedly affected. This boy was able to walk, and he has no idea to have a stable gait, and is severely affected from a gait and truncal ataxia. This boy responded very well to monthly dexamethasone treatment, and his outcome was actually very good without any sequelae. This video from a colleague, the girl is at present, or was at the time of the video, 4 years old. She has been into her illness already for 1.5 years. She has a kind of a multiphasic, but with a secondary progressive component, and you see she has a markedly gait and stance ataxia. And she has no idea to walk securely. And what you can not so well appreciate, that she has a polytope myoclonia affecting mainly the upper trunk. This child had all the immunological drugs you can imagine. And only at the age, I think at 10 years after receiving multiple courses of cyclophosphamide, her disease was stable, and she turned out to be actually majorly affected in cognition and gross motor skills. So you have seen two very diverse kids, one doing very well. This is a child with eye movements refer to our attention with the question of opsoclonus. And what you can already see at the video is that the child is below a year old. The child is doing well, is not distressed. And if you characterize the eye movements in detail, they are mainly horizontally, and they are not chaotic and extremely rapid. But many experts have seen this video and with conflicting interpretations. But to say the child didn't develop any other symptoms such as this is a video we recently got to evaluate. I would describe first the child has head nodding. He's happy. And his eye movements are more random but also not very chaotic. So also a difficult case. He had no sleep problems, he had no ataxia, and he has no myoclonic jerk. So at present, we would characterize this as a eye movement not reminiscent of opsoclonus. You see, it's not that easy at the beginning. If you have the full picture, it is straightforward, but in the beginning, and that's a big point because people think in the field that the earlier you treat these children aggressively, the better the outcome is. So some facts. Monophasic, probably 10%, the majority is multiphasic. Few improve with steroids alone, and most of patients I know and from other people need more than one medication. And that's probably the most important point of the talk, is that studies suggest that 2/3 of children develop delays in all major areas of cognition. And that has been shown by various studies now. So what's the cause of opsoclonus myoclonus? And I think it's a kind of model disease. We know that it's triggered by infections. We know that children who had a neuroblastoma and were treated with immunosuppressive drugs, they do better at the end. And histopathological studies already have shown that in the tumor you have abundant T and B cell infiltration, and in particular of low-grade neuroblastoma. So the immune system is working with the neuroblastoma and probably causing things called such as molecular mimicry. And a group by Prasatelli, but also others, have shown that if you look at the CSF of children with opsoclonus myoclonus, you have in the majority of children an increased cell count, and you have a B cell subset expansion in the CSF of children with OMS. Even more important, you have an intrathecally production of CXCL13, a mediator for B cell attraction and overexpression of certain receptors on CSF memory cells. BAF is upregulated in the CSF of children with OMS, and we know now that children who do receive rituximab or monoclonal CD20 monoclonal antibody improves the outcome, most likely in the majority of kids. At least abundance the clinical symptoms more rapidly than other medications. Several groups have shown that if you look at the serum of children with opsoclonus myoclonus syndrome, there must be antibodies against neuroblastoma cell lines. And more recently, and I think that's an important work by Dalmau and his colleagues, they showed that they studied 40 patients with opsoclonus myoclonus. The majority of them had no neuroblastoma, and they detected in 4 patients antibody against dendritic neuronal surface antigens in opsoclonus. That opens a different avenue of targets and is an important step showing that at least a subgroup of patients, antibodies to various structures play an important role. Now, to conclude, therapy in OMS, we have steroids, we have immunoglobulins, rituximab, but we have clearly to state that no single agent was tested in a prospective trial. All we know is that experts agree that therapy should begin as soon as possible, and the therapy should be continued for at least 1 year. And in the event of a relapse or worsening, you should increase your armamentarium of medications, and you should escalate therapy. This is the European trial, which has opened in, I guess, in France, in England, Denmark, and the first step is that patients receive dexamethasone. If they do not respond quickly, they receive immunosuppression with cyclophosphamide, and the third step is rituximab. And there's certain criteria when they switch from step 1 to 2 and 3, depending on the clinical presentation. And this is probably the first attempt to get some information about the outcome. So in summary, OMS in children is associated with a significant disease burden in the long term, and long-term neurological cognitive problems are very common. And as I stated, therapies should be evaluated in prospective trials, and most likely immune-mediated processes play the most important role. Thank you very much.
Okay, thank you very much for the interesting presentation. Do you have any questions? Yes.
Большое спасибо за вашу презентацию. У меня такой вопрос. У нас есть небольшой опыт ведения 25 пациентов с нейробластомой и синдромом псоклонус миоклонус. И основные методы диагностики, которые мы рекомендуем, это проведение компьютерной томографии или МРТ, потому что у половины из этих пациентов ни при проведении рентгенографии, ни ультразвукового исследования, ввиду малых размеров опухоли, она не обнаруживается. Скажите, пожалуйста, на ваш взгляд, если при компьютерной томографии и МРТ опухоль не выявлена, имеет смысл проводить сцинтиграфию с МБГ, либо только когда опухоль выявляется при проведении уже других визуализационных методов? Спасибо.
I think the neuroblastoma specialists recommend to do the MIBG scan in order to detect even smaller tumors which are not detected by MRI scan. Is that correct?
Да, спасибо.
Okay, any more? Okay.
Спасибо большое за вашу презентацию. Все было очень интересно. Поскольку мы ведем специально группу детей с паранопластическим синдромом и нейробластомой, у нас таких пациентов много, у меня обратный вопрос. Скажите, пожалуйста, если у пациента есть синдром псоклонуса миоклонуса, но онкологи, консультирующие вас, после проведения всех возможных видов визуализации, исключили наличие опухолевого образования, есть ли какие-то рекомендации для этой группы пациентов продолжать визуализацию в течение какого-то времени? Я поделюсь нашим опытом. В нашей группе пациентов мы наблюдаем вместе с неврологами более 40 пациентов с нейробластомой, из которых более чем 50% детей есть выявлена нейробластома. Есть группа пациентов, у которых симптомы псоклонуса миоклонуса выявляются ранее, чем у них дебютирует и может быть диагностирована опухоль. И даже в условиях проведения исследований в одной и той же клинике, в одних и тех же руках, мы продолжаем проведение КТ, МРТ исследований в течение 2 лет после дебюта синдрома раз в 6 месяцев. Я могу сказать, что у нас есть небольшая группа пациентов, у которых псоклонус миоклонус дебютировал ранее, чем была выявлена опухоль. Вы встречались с такими случаями? Какие рекомендации как невролог вы можете дать тем пациентам, у кого псоклонус миоклонус синдром есть, а опухоли нет?
You're talking to a neurologist who doesn't see children with neuroblastoma, but I've learned from my colleague that if you have a patient who does have a relapse, for example, after a year, you should repeat the investigations. From an immunological point of view, I would say that the immunological system has most likely cleared the tumor, and it is very rare that you detect a tumor after a OMS disease course of more than a year, according to my experience.
Хорошо, извините, чуть изменю вопрос. Если у вас есть группа пациентов, которых вы наблюдаете с абсоклонусом и оклонусом, рекомендуете ли вы этим пациентам, примерно раз в 6 месяцев делать МРТ и КТ для того, чтобы попытаться найти злокачественное, доброкачественное уже новообразование? Нет. То есть мы говорим только о тех детях, у которых был установлен диагноз нейробластомы параллельно или до того, как был установлен диагноз абсоклонуса и оклонуса. Спасибо.
Okay. Okay, thank you very much.